Good morning.
Good morning.
Well, I'm very pleased, and I think we all should, to have René Chapot today with us. I would say René is today the number one person leading uh, endovascular neurosurgery. He has done tremendous work, not only in the management of aneurysms. He's the first one to have really started treating aneurysms of the middle cerebral artery with dual balloons. He has done the transvenous approach to brain AVMs. And I asked him to present to us something to think out of the box. And the reason or the thought behind it is the number of things that we have when you're doing open neurosurgery, when you're doing, endovascular neurosurgery. There's many situations, many times that don't fit the norm, and how do you deal with those? So I asked René to please show us some of the things how he responds to these difficult problems where the solution has to come from your imagination and your creativity. uh, René is a incredible person. I have been with him many times, worked with him. He has been with us at Sinai many times now and helped us with difficult cases, including newborns and transvenous approach. So without further, would like to see and listen to René.
Hello, good morning. I'm very happy to have as a chance and the opportunity to share some of our thoughts. And I'm going to share immediately my screen so that I'll be able to, share the situation where we are wondering what would be the best way to do. Let's go on with what I call antegrade access to retrograde feeders. One of the main limitations in endovascular treatment is that a lot of vessels are not accessible. And here, if you look at this AVM, the AVM, which you hardly see here, is in the MCA territory, obviously. But this artery here is coming from the ACA. The ACA gives a bunch of anastomosis and then fills this distal MCA branch that comes retrogradely to the AVM. The same thing here in the magnified view. And getting through these anastomosis, sometimes it may work, but usually it's through real pain and it does not work. So the problem is how to get access to this, because usually it's a point where endovascular is limited and cannot go beyond. And here another AVM, which is this time located in the ACA territory. But look how interesting it is. You see that the ACA, that comes mainly here from the right ICA, gives part of the AVM. But if you look on the other side, if you look at the left ICA, you see that most of the MCA here is fed by numerous anastomoses that come from between MCA to ACA via all those little vessels that we can hardly access to. And if we look more into detail, we bring a microcatheter and we see that indeed this does not look good. We won't be able to do it. To analyze how those anastomoses are, best is to place a microcatheter, and the microcatheter now we change on the lateral view. So the microcatheter almost reached the cortex. And here are too many small arteries that you cannot cross, but which fill this artery that is now well to be seen. And this one here is a distal ACA that fills retrogradely back to the AVM, which is aspirating because of all the shunts. So this is the goal, how to get there. If we try to look antegradely before an embolization, and probably this is a key message here, if you start to embolize, it's the best possible vessel. Usually you take off the ability to reach this one. Because if you look here at the different ACA branches, everything just goes to the shunts and you lose the course of the normal pathway. But it is here. And if you're convinced that it is here, we have some imaging modalities that show more. Here it was before we were doing those imaging modalities. You guess that you must reach here. You look at both planes. And here's a navigation with the wire where at some point you may see that it was possible to make it a bit more accelerated. Here, the wire was going to the shunts, but at some point here, you see that we're about to reach the artery that we could not get access to. And that's very interesting, because once we do this, let's say this is the AVM, this is anterogradly, this is a hidden pathway of the artery, and here we get access to those arteries that we cannot get access. And once we achieve to arrive here, which is surprisingly much more reproducible than you could originally think, the only thing, you have to search for it. If you don't search for it, you will never get it. But if you search for this, and once you get this point here, then you just trap the artery, meaning you bring another catheter. With catheter number 1, you occlude with coils on both sides. Catheter number 2 is left inside to occlude all the shunts simultaneously. Here's some additional glue to avoid any more reflux. And this is what we could do here in this patient. You see that this is the single feeder where all the corresponding shunts were done. So this is before and after step 1. On a similar way, after step 2. And now the rest is just that you have the vein, which is well accessible, not too many arteries, so the risk of getting here transvenous is not too high. And here, by getting transvenous, you can cure this AVM. So this has become one of the major things in our practice, to find a way to get an antegrade access to retrograde filling arteries. Okay, but transvenous definitely is what it was changing our life. It's absolutely incredible how much can be reached by this way with different difficulties. The veins are sometimes easy, sometimes they are not. Sometimes it may be indeed the limiting factors. This young guy ruptured his AVM, the location is temporomesial. You see here the runs where it's mainly fed by the ICA. There's something also coming from the PCA, but we don't need to see. And here again, if we look here, we see that it goes up to the great vein of Galen, but then unfortunately, the great vein of Galen is occluded. The junction to the straight sinus is done, so you need to find a way, and this way is either anastomosis coursing here along the midline, or the other basilar vein that goes around the temporal lobe, joins the cortical vein and gets to the sinus. And it's a quite long way, but this is something that can be considered. You can do different rotational angiograms that show better the connection between both basal veins of Rosenthal. And finally, here is the course that we had to follow. You see the catheter here in the tip of the catheter in the left lateral, then superior sagittal. Look at the lateral view. Now there's always a U-turn, getting down that vein, now around the temporal lobe, arriving in left basal vein and getting up to right basal vein. And indeed, with some patient, it works. And you can even manage here. We place 3 microcatheters in order to control the vein. You may see here one vein, one primary vein, the second one. So we place 1 catheter here, a second one there. I hope that you can see my mouse, and a plug here, which enabled finally to cure this AVM. So sometimes the way to the vein is tricky, but not always. And in fact, much more important than the difficulties of navigation is the difficulties of understanding. And we entered something in our practice. I had the pleasure already to share some discussions and talks with you 2 years ago. And at that time, we did not go on into this type of imaging that we call 60 imaging. And I want to share with you, here's a patient that we treated during our last live course. She has this frontoparcular AVM, but it's not the only thing. The problem is, on the right screen, you see the AVM. Then you go on the left screen, you see that one on the course of the outflow vein, there is a venous aneurysm partially thrombosed, which, go back to the right screen, induce a cystic reaction. So 3 problems: AVM, venous aneurysm, cystic reaction. And between April and November, the cyst grew a lot. She did not bleed, but you cannot leave her like this. And she is surprisingly asymptomatic, despite all these not good looking pictures. So here are some, I would say, transarterial embolization. I won't go into this detail. And now we reduced it significantly, but the AVM is still there, fed by the left ICA, some frontal branches, and left by some indirect frontobasal branches coming from the ACOM complex. And this here is quite well accessible. It's not completely straight, but you can put a magic, you can arrive here. And the question which is raised here is, can we occlude this? Where should we stop with occlusion? And here's a point I want to introduce here is what we call 6D, which is a fusion of different volume imaging, which means we make a rotational angiogram based on this microcatheter injection. And we made another rotational angiogram based on no lower injection of the AVM from the left ICA. So this is what you can see here. Blue is injection of the left ICA, and orange is where we are. And because of this, we can very precisely understand what's going on. We see that our microcatheter is somewhere here. This is a shunt that we're filling. And this is very clear that you see this vein arriving in the main outflow vein. You see how the contrast here agent is diluting. This is here's the main outflow vein of the AVM. I'll go back. Here, before you see that vein, which is coming from here and getting up to this part. So this is distal in the course. And if I follow this vein here, if I follow this vein, I can see that this vein is arriving now to all the shunts. Here are a lot of arteriovenous shunts. So if I go back again, we follow the shunts. Here's the AV shunt, the primary vein. You see here that large outflow vein. Downstream, downstream, downstream. You go here. Here is some onyx that was lost during a previous injection. And you go down, and here you arrive with this little shunt that we're just facing. Imagine if we would embolize from here and occlude that vein, the AVM would go up. It would just bleed. So understand, this is crucial. And this is, in my opinion, the best way to understand it is by doing this kind of imaging that we've just been developing, and Siemens is about to take it over now. And this allowed us here, this patient, to first put catheters in those veins here to treat two shunts before we occluded the last one where the microcatheter was in place. Here we see again, this is the main outflow vein, which divides in secondary congestive veins. And the course where we were located was somewhere here, which is very downstream the main outflow vein. And you see after treatment of this patient here, this AVM was done, and patients are...
How are you doing? Are you fine?
Doing fine.
Yes,
and
can you raise both arms?
okay, we don't need to go more into this, but definitely pictures is not the most important, but how our patients are doing. Let's look at this guy here. He's young, he's 30 years old. He bled a couple of times, and the AVM is extending in the whole corpus callosum. And to analyze this, you see also that it's fed posterior to splenium by the posterior circulation. And to understand how all those vessels combine, we put in orange the ICA, in blue the posterior circulation. And here we can clearly see, look how we can properly find the course of the veins. We have no doubt to understand that this is a vein. This is here's the anterior vein that is going up to there, but we see also here another posterior vein, this one that goes up there and that drains all this part. So because of this, we can analyze properly the venous segmentations. How do all primary veins come together to get inside the main vein? And this gives us the key to further go on here with stage transvenous. So we decided to go to the very anterior vein. Here as a microcatheters. Here we do what we call a retrograde venous pressure cooker to limit a potential diffusion of embolic agents throughout this vein. And then we occluded this part here. You see this is ongoing embolization. And finally, we occluded the whole anterior part which now is occluded. This is remaining. And this is for further step, where I wondered whether this could be done within a single procedure. But when looking at more into details here, anterior circulation, here posterior, it's not that small. So the challenge while going by transvenous is, are we going to be able to occlude all shunts if the vein is being occluded? And if we fail, the AVM may bleed. So we must be pretty sure that we'll be able to occlude all shunts. And that's why the less there are shunts, the more likely we are to achieve our results. And this here is a fusion of this early venous phase between anterior circulation and posterior circulation. So we see that these veins somehow combine. These are the veins, primary veins coming from the anterior part, and these are the veins coming from the posterior part. And if we look at this here by, again, our 6D analysis, fusing the ICA in orange and the PCA in blue, this kind of picture is just good looking, but that's a marketing picture. It does not help to understand how the veins do combine, but here we see it very well. Orange is, of course, when there is a mixture of blue and I mean, green is a mixture when there's a mixture of blue and orange. And here, so this is the outflow vein. And if we follow this outflow vein here, you may see here those blue veins. This is what I'm pointing at now, which are the veins coming posteriorly. And those veins coming posteriorly are these ones. Once we understand them on the 6D, we can look with a microcatheter through the different arterial feeders until we find here both veins joining to this main posterior vein before it goes to the AVM. And once we can see it, then we can get access to it, we can pressure cook, we can occlude that part, so that after treatment number 2, the posterior part has been occluded, same than anterior part initially. And you see that that is here remaining. But look, the very impressive thing in doing transvenous is that the chance to create arterial ischemia, which in my opinion is very frequent when we do arterial embolization, is much lower. And on DWI, we have almost no ischemia to be seen. But on FLAIR, on T2 pictures, we see that there is significant edema. The fact to occlude veins always brings this edema, but which is always resolutive. That's the important thing, that the patient 2 days after treatment, you see how well he's doing. I mean, it's just a picture, but I can tell you he's doing well. Third treatment, very similar way, and this patient is cured. And again, he's cured, but he's fine. I mean, that's a patient again, 3 days after step number 3. So this was this patient, but just to focus on pericallosal AVM, this here is a 12-year-old boy from Belgium that bled, where we occluded the AVM in 3 steps. This is here a 49-year-old patient from Austria, 2 steps to finish his AVM. This here is the 30-year-old boy from US with this large AVM. Within 3 steps, we could finish. This is the lady that comes from France with this large AVM, which required several steps, 6 steps. And this here, I just finished him yesterday, the patient from Israel, where you see that it took 2 sessions to finish his AVM, and he's doing fine. So I just focus now on pericallosal AVM, because pericallosal AVM have the advantage that there are no single plane, and the understanding of the veins is easier. Then look at, it's just like this pear tree, which is now a palisade pear tree. It's just grown up against the wall. But nature is very often something like this. This is another pear tree, but which is a 3D volume, just like this AVM, whereas the understanding of the vein is more challenging, but where this type of imaging that I just showed is very important. Also because angio is the most precise way to understand, but angio is very frustrating because we just see one artery and we don't see all arteries together. So if we mix here those pictures, we can really precisely look at how the veins come together and then we can define which vein we want to access primarily, which arteries we need to control. And this way we can treat and cure those kind of pictures. Before, we used to do those kinds of pictures here to analyze the MPRs on a single acquisition, but it was just black and white. And now that we have the color, in my opinion, it's an evolution from black and white TV to color TV. We just see a lot more, and I wouldn't go back to what we were doing previously. Okay, so I've been looking at the veins in AVM, but for dural fistula, we can access to these veins on a similar way to treat them and to cure this. But much more important in dural fistula is to control the vein. And control the vein means if you're facing a regular fistula, there's always a good artery accessible and a lot of arteries that are not accessible, where then when we start to embolize, some embolic agent goes to the sinus. And as soon as it reaches sinus, there's a balloon that we developed, which is a very compliant balloon, so it does not compress the dura, and which allows diffusion from here to the non-accessible arteries. And this changed our life for dural fistula, because this way we can cure dural fistula with a single step of transarterial embolization under control of this balloon, which of course, this is a very simple one. There are situations that are very ugly because the sinus is just extremely large. And here there had been many attempts. Here's the left side, here's the posterior circulation. Look at all those meningeal arteries coursing within the forks. And same thing from the other side, extremely large. So we had to use 3 10-millimeter balloons folded this way in order to be able to control the shunts. But then we could inject retrogradely all the meningeal supply and indeed finish this fistula. And again, the most important is not only the tool to allow you to do something, but much more to understand. And look at the sinus here. Again, dural fistula, where we see a sinus which is open. But what can we say more on the sinus? How much is it okay? How much is it diseased? It's quite difficult to say. The analysis of vein is usually quite poor. But if we put a balloon, look how diseased the vein is. By placing a balloon, it's eyes opening. You realize that the vein is completely pathologic, is almost occluded at some point. And this we can analyze because the balloon is very soft. If we would take a high pressure balloon, we would just crush all the fibrosis and we would not recognize how anatomy is. Or another situation with this duplication in the sinus, which is quite more frequent than we expect. My question to you is, where are the shunts? Are they in the inferior or in the superior branch? And really, I don't know. And I don't think there's any way to know. So we place the balloon here at 2 arms. We place the balloon first in the inferior arm, fistula is patent, and then we move from the inferior to the superior arm, and the fistula is gone. So as soon as we understand, we can act accordingly and then protect the superior arm in order to treat the fistula here, to keep both arms open. And another evolution that we found out in our practice is, since we're playing with balloons, we can handle those kind of fistula that are indeed much of a problem, because everything which is located close to the skull base is fed by meningeal arteries, which embolization is at high risk. We have a high risk to create a vasa nervorum ischemia by occluding the supply branches to the facial nerve, if it's a stylobastoidal artery or other nerves. And here, if we cannot embolize by the arteries, and if we don't want to occlude the sinus, because if there is no sinus on the other side, what we do is to place a balloon, it's a soft balloon, with some microcatheters being at the junction, trying to get retrogradely. But you see, we could not get so far away, but we block the vein. And by blocking the vein, we can inject retrogradely from the vein to the shunts, which enables to occlude the fistula. You see that the balloon is deflated, but not only to occlude the fistula, but to keep also the sinus patent. So the more we have tools, the more we can play with it. Very shortly, a couple of other things. Accessing to the vessels is, of course, best. I mean, best is quite often good by arteries or vein, but we have other ways to do when those kinds of tumors here don't embolize by getting through the arteries. It's too much time consuming, it's too less effective. Just take a needle, puncture it, and onyx diffuses on a very nice way. This procedure get, because of this, very rapid. It just takes 30 minutes, and we occlude arteries and veins, which makes it become avascular. And you see here that those non-accessible feeders from the posterior circulation are done. So definitely direct puncture is a very nice way to proceed, but not only for tumors. Here is a patient that's, I think, 20 years old. She had some SAH, and the dural fistula was located at the inferior edge of the forks, with no supply from the internal circulation. The only supply was this occipital artery, which was getting transcranially through the parietal foramina. And definitely you cannot navigate here. So if you want to go endovascularly, if you check what is this here, this is a parietal foramina, that you can see on different imaging. On the skull base, it's a hole that is very often or more or less present or seen. And if you see it, then you can place a needle. Here is a tabula interna and externa. So when you puncture with a needle, of course, not to go too far away. And once I punctured with the needle, I placed a microcatheter inside, and this enabled to cure the fistula. So using the different foramen is a potential way to get access. We used to do some direct puncture through burr holes to get access to fistulae. We don't do this anymore. This I learned when I was in Lariboisière 25 years ago. I don't think there's any indication for this left, because we can recanalize the sinus. And this is a type 2B fistula here, where the sinus on both sides is occluded. And that's why the only outflow goes to this retrograde filling temporal vein with a lot of cortical veins that are being filled. There is no good outflow. And of course, edema and symptoma. And today, recanalizing is not that much of an issue. You can recanalize here, and once access is given to that part, of course, we can occlude it. This would cure, but why not to restore, as we already recanalized, which means we take the compliant balloon, we make a kind of knot, we can U-turn here, and then accessing through the arteries, we occlude the fistula. And since the sinus here was occluded, we have no risk in placing a stent there. I mean, if the stent re-occludes, then we go back to previous situation. So we stented it, and PTA stenting, and after stenting, you see that we could restore a normal outflow, and edema resolved very rapidly. So reconstructing the sinus, same situation here. All the sinus get progressively occluded because of the dural fistula. So we recanalize, protect here superior sagittal, lateral, straight sinus, and then we reconstruct, occlude, and doing serial extensive PTA with extensive stenting enables to restore a venous outflow. This is always the point. Dural fistula are two diseases. One, the shunts. Two, the venous disease, that the veins are not correct. This is immediate result, but we have 15 patients with something like this with a 1 year follow-up that shows that this is kept patent. It definitely works well. So aneurysms, I'm about to finish. I don't want to make it too long. Aneurysms, that's so many ways to treat aneurysms. I think that we should rather focus on our failures, because we're in a situation where what we do is not good. And then we need to find a way how to be out of trouble. And this kind of large aneurysm here, you may see a spinal artery, and this has been treated by many ways, coiling, and then there had been some stents, and then some flow diverters, but it's still growing. And that's one of the things which is usually under considered. The angio looks good, but who cares of the angio if the patient is not doing fine? And if indeed the aneurysm is still growing, this is of the main concerns I do have with flow diverters, that sometimes the aneurysm, the thrombosed aneurysm still grows, despite the fact that the angio looks super good. So what else to do than adding flow diverters? So I added 1 or 2 flow diverters here. And after deploying the second flow diverter, the patient became with a strong bradycardia. and I did not see anything except that the anterior spinal here is gone. We lost it, and our anesthesiologists were having problems not understanding why he fell down to 30. And I wondered whether this could be related. So the only way to do here is to take the flow diverters, the pipeline out. So we developed a technique. We published this last year to combine stent retriever and snare. Stent retriever to anchor, and snare to take the flow diverters out. And interestingly, as soon as the flow diverters were out, the artery immediately reappeared and the bradycardia was gone. So definitely some central origin to explain this bradycardia was the cause of it. Last point, and then I'm going to finish, is another situation where we have failures of flow diverter. I mean, endovascular physicians love to place flow diverter because usually it's not too complicated, putting potentially a coil, so treatment is being done, but the aneurysm here is growing. It's not done. You see that the coils are there, and this is still growing. So what to do here? Of course, adding other flow diverters, but experience shows that usually does not work as well as we would like. It's not the end of the game because you add a second layer. Indeed, what we need to do is to make this layer being completely occluded. We need a kind of covered stent, but there are no covered stents that do this. So if there are no, we create ourselves covered stent, which means, we could find a way here to go through. There are some small catheters that enable to go through, but in addition, after coiling this, we left the catheter in contact to first flow diverter, placed a second flow diverter that we deliver here. So between both flow diverters, we sandwiched a microcatheter, which is in place, and then added a balloon. So we have first flow diverter, microcatheter in place, second flow diverter, balloon. And then we add some liquid embolic, some onyx, which will make the flow diverters being closed. You may see it here. Here is some of the onyx that is being injected around. And it may go also to the aneurysm. It diffuses here. Of course, we made sure before that when occluding here, the flow was reverted in the ophthalmic. Otherwise, I wouldn't have done. And now we have been injecting enough onyx in between. And you see that this is the after. And some 6 months follow-up showing on MR that now the aneurysm is reducing in size and now it's not stopped to grow. So here is a little overview of many ways what we can do, and definitely I don't pretend that we can solve all problems, but we have tools that help us to do a lot of things, and the limits of what is being done are constantly shifting, and that makes it very interesting. Thank you.
Very good. Thank you, René. Super, super nice. Peter, can we take questions? Chris, can we take questions?
Yes, definitely. We've got a few minutes here.
Yeah, we have about 15, 20 minutes.
Okay, I think it's quite spectacular what René can do with flow diverter. By the way, where do you get those balloons? You know.
So the balloons for the sinus, I pushed the company to develop it because there is no available, and it's interesting technology because the diameter of the balloon is changing along the course, and the polymer which is used is changing from one end to the other one. The requirement was that it was large enough, so the diameter is 8 or 10 millimeter and enough length, because the ways the vein joined to the sinus is always a delta. I tried to do different occlusion tests of sinus occlusion, and you see that the cortical veins always go around on one side, on the other one. So those balloons needed to be long enough.
This is made by Valve, correct?
Valve, yes.
Yeah. Unfortunately, I don't think we haven't yet in North America.
So we're gonna have to have it. It will change.
You have to come more often with a luggage full of balloons.
Dr. Chapot, thank you so much. That was really exciting, and a whirlwind tour of some of the things you're doing. Can you talk about how your transvenous AVM embolization selection criteria has changed over time as you become more comfortable with the technique? What were the original cases you were doing, and what kind of cases are you doing now?
Indeed, indication has been enlarging. I mean, first patient in 2003 was a lady that bled 10 times, that had a very small AVM and a super easy vein, and small enough that I dared to do so. But in the meantime, we enlarged to a lot of grade 4 and 5s. These are most of the AVMs that we treat, because these patients are not treated, and it's good that they are not treated, because treatment is dangerous, but they're not treated up to the point when they start to bleed. And then they have 1 or 2 bleedings, and then a solution has to be brought to them. Definitely venous is not always the only thing. It's a combination of things, and first transarterial in order to reduce it as much as possible, and then trying to understand the veins. And I would say, if here, my hand is a venous segmentation with a main vein and different primary veins arriving, the whole point is to find veins that are isolatedly to be identified, so that each vein can be occluded, so that the AVM can be occluded step by step. If we need to do a lot within one step, it is more dangerous. Probably that's the reason why my risk of bleeding did not reduce with time. I'm still something between 5 and 6% of bleeding complication, which is not so low. But I would have expected that with time, this rate would have been doing better. And I'm quite frustrated it's not. But I think that among the patients that we treat, we've been enlarging the range to very challenging ones. I still believe that AVMs in the brainstem, whenever we occlude the vein, even if we don't create an arterial ischemia, the patients are disabled. So I don't think that that's a good indication. But all deep ganglia stuff is to be treated, taking into account that when there's this phase of edema, the patient do have some symptoms, but they're transient. As long as there's no ischemia, and really you can differentiate. I tried to show it on some pictures on MR. If you have no lesions on DWI imaging, then there is no arterial ischemia. And we all know that venous ischemia is reversible. Just look at patients having extensive sinus thrombosis. They're doing very poor, and at some point they do very well, because this edema is reversible. And I think that we use the same principle when we go on by the veins.
Great, thank you.
René, it's Reid DeLacy here. Really good to see you again, and thank you so much for your time. I love watching you speak and seeing your experience and cases that you bring. There's 2 real points or questions. The first comes to the 6D imaging that you showed. And I think that's a major step forward in helping us to map and understand these lesions and approach them in a safer, more effective and scientific way to treatment. The second, I guess, is, pardon me, a little bit more philosophical. And I'm wondering, in light of the currently ongoing prospective trials like TOBAS and TATUM, where you think transvenous and approach to curative treatment of AVM is really heading in the future, considering all the amazing work and pioneering work that people like yourself and Charbel and Murray have done in the last 15 to 20 years?
I don't think that AVM is a very democratic treatment, because even if there is a recipe, the amount of efforts for each patient is a lot. It's not a fast treatment, because the risk, if something goes wrong, is potentially devastating. And that's why I wonder how much 2 studies are able to show the results. Look, some very basic treatment. Carotid stent now is being done since 20 years. All the studies show that there is more or less equipoise between the different techniques in terms of efficiency. But a study run in France about carotid stenting, EVA3S, was stopped after 15 patients because there were 2 major complications. So if already such a simple technique fails, how do you want studies with challenging and demanding techniques to bring on good results? I think that the learning curve is quite long, because usually when I'm shown complication, the comment is, we've been going through the vein, we've been occluding something, then there was no AVM to be seen, and we stopped and the patient bled. The problem is when you occlude the vein, you won't be able to see the early vein anymore, which is usually the criteria to say the AVM is still there. So that underembolization is probably quite important. I did not mention, for instance, a point which I believe is super important, which is to have embolic agent with less viscosity. So viscosity now of onyx is based on one simple fact, which is the ability to plug. You inject, it goes in all directions, and at some point it plugs so that you can inject it to the desired direction. By making it more diluted, you cannot plug, which is the reason why engineers of MTI that developed this product said we don't want to make it more diluted. But in fact, if you create the plug on another way, then you can use this more diluted embolic agent, which likelihood to fill all the shunts is much higher. But reversely, if this likelihood is higher, then at some point you have the risk of having some embolic agent reaching these arteries, the arteries. So that's why maybe you saw, but I did not want to go into these points too. In some patients, especially the pericallosal one, when we embolize through the veins, we place preventively a stent retriever in the arteries where all shunts come from, because if we continue at some point, we will reach the arteries. So all those factors have to be considered, and that's why it's great, it works, but I think that AVM treatment will and must remain in centers where this is being done often.
Yeah, I think it's a confusing kind of process to get to an evidence-based approach to treating these AVMs. People obviously have really, really good intentions in designing these trials, but you know, it can certainly lead to setbacks that are unintentional in the progress of the field.
Do residents have any comments, or anybody else? Dr. Fifi?
I just want to say I enjoyed the talk a lot. I think I want to echo what you guys were just saying, that it's a very the treatment is not a cookbook, so it is something that it's near to impossible to put in a clinical trial if you're randomizing. But I think you did say that I think I heard you say that for the higher grade AVMs, you always wait for hemorrhage before treating. So I don't know, is that correct? We're not at the point where we would take high grade AVMs and do this kind of pre-symptoms or asymptomatic patients.
Let's say it this way, recruitment is growing into this direction. How much do you need to wait? If you see that the AVM is changing, that venous aneurysms are growing, at least they need to be symptomatic or evolutive to offer treatment. And then I can just give the results that we have, and the patient decides whether he wants treatment or not. One thing is still impressive: if patients are offered treatment, the number of patients that want to be cured is very high, definitely. So it's all about giving on a fair way our complication rates for them to be able to decide whatever they want to do.
René, what would you quote a patient with a great, Martin-Spezler? By the way, can we use that classification, the Martin-Spezler? That applies to what we do. But what would you tell a patient with a large malformation in so-called eloquent area? What would you tell the patient?
So how much is Spezler-Martin for us relevant? There is one good thing: the vein, the deep vein, which is surgically an issue, appears to be for us an advantage. So usually we all have the same advantage and the same drawbacks. luckily now, for once, we have one point which is for us an advantage, because very often the deep vein is a very good access to the AVM and is rather better accessible than the other veins. So it still means that it's a difficult AVM if there's a high grade. So what to tell them? I tell them that I've got a risk of bleeding per session of 5.3%. And well, if you compare those data to the data of Ben Carlson with a spontaneous risk of bleeding between 3 and 4% per year, patients know those data, and at some point they decide whether to treat or not. But definitely the fact to be able to step down, I think also that there's an important place for combined treatment. I think that the cortical AVMs are not the one that were the best. I'm not sure that we're so good. I think that for all the deep part, we can treat the deep part, and how much cortex, the veins, analysis of the veins there is not so good. And I really believe that this could be a very good way to proceed for us to treat the deep parts, to downgrade the AVM for it to be surgical in the second part.
I have a practical question, like how many AVMs do you think, and this is just a could guess, do you think that you would need to treat overall to be comfortable doing this technique, like the training for this technique? How many AVMs would it take?
To become reliable, many. I mean, I don't know, 10, 15 years to have less fear in treating an AVM.
How about talent?
Yeah, there's a comment that I don't think it's for everyone, even as we've been discussing, like the experience, and then also the ability to deal with complications. You have to have both, I think. Yeah.
Right.
Joanna, I think that it's hard to say how many you would need and so on. I think the key is to understand this principle that René has introduced, which is the primary veins, dedicated veins, to understand which veins you can sacrifice. The technique of pushing the liquid is not, is the judgment of when to do, when not to do, how much to do. That has been AVM treatment all along, including the surgical treatment. Which vein can I take surgically to use it as an anchor to dissect? So I think that the imaging that, by the way, the imaging that René shows, was that all in the new Iconos system?
Yes, you can do it on the old system, but it's much less reliable. So Icono is, I think, is becoming the key to do those things.
So we're going to need it at Sinai main campus. Okay. I'm not sure we can get those kind of images. Maybe the new room that is going to come to West will be able to do that. But that's something that we need to discuss, Joanna, because no matter how good you are, if you don't understand what you're doing, you're not going to know what you're doing.
Yeah, I think that I agree. I think most of it is understanding, but I think that it's not to understand the complexity like you're showing, René. I think you need to look at probably hundreds of AVMs to understand, to be able to understand completely when you see next one. Yeah. But our room can do 4D, and it can merge 4D, but it's not, we're not getting those pictures unless Reed knows.
No, I mean, I think René showed some beautiful evolution in the way that we approach three-dimensional structures using multiple parameters with DSA, and how much it's changed in the last 5, 10, or even 15 years. But hopefully this is just the beginning, and the kind of imaging applications that are coming into neurointervention or spine surgery or open neurosurgery are just going to keep on evolving and make it easier and and more straightforward to us to understand what a really, really, truly very complex lesion.